developing world, the poorest 20% of people are served by only 2% of the world's doctors. In 1982, a young doctor named Ronald Pust at the University of Arizona designed a new interdisciplinary course, Global Health, Clinical and Community Care. This program was one of the first medical school programs in global health in the country, operating on a shoestring budget and overseen by just a few dedicated physicians and teachers with a passion for global health.
At the time, I had never had any intention of coming to be on the faculty of any medical school at all. I was invited to look at a job here, and lo and behold, it must have been very hard up because I got it. My passion has been all the time to put the public health perspective into the lives and thought pattern of physicians. Global health didn't exist when I came, at least not in the current iteration. So we were frankly a pioneer in even thinking about teaching medical students or any clinicians about global health. The deal that I made with the bosses that I had at the time was that if I did what they hired me to do, which was teach medical students about basic primary care, that I could start looking into global health, and this happened in 1982. Since then, we have run 34 consecutive courses in global health.
It culminates in an internship away in a developing country for 6 to 8 weeks. Students have practiced getting a lot of information as quickly and as independently as they can, with little opportunity to process and interact with each other. And this particular course is a classroom. There are learners from multiple disciplines receiving new information so that they've all come from different backgrounds, and they can talk about that. Dr. Pust, from the get-go, one of the requirements to teach in this course is that you need to be involved in global health.
I think going in, people say you're going to do a global health class, you think you're going to learn a few things here and there. But I think for me, what I really liked about this class is they bring people who are really passionate about global health, who have been in the field for multiple times, who have been in different places to teach you the different things you can do in these settings. And so you have people who know what they're talking about.
The approach may be more than other global health programs in focusing on what you need to know before you go. There's a dozen of us or more in this program that teach, and they're not all family doctors. They are from many different specialties. They have many different passions, and more importantly, they have been on the ground. We don't let anybody teach in our course unless they've had practical experience. I don't care what the rank is academically. So they have to be good teachers, and they have to have had field experience. The concept in designing the curriculum here is to make it based on what works. Largely, that's based on research that was actually done in those countries.
The Clinical and Community Care course is unique because of the emphasis on community. Students learn and practice using appropriate technology for the developing world.
There are a lot of people in my world, in the surgery academic world, that see global health as spending 2 weeks in X country doing total hip replacements, or spending 2 weeks in another country doing a bunch of hernia repairs. And while there's value to that, those are such a small sliver. This course had nothing of that. It didn't even occur to me back then that people did these kind of 2-week mission sort of things.
It's really a unique course because it's not taught in the traditional public health environment. It's taught in a clinical setting, so clinicians get to also understand the public health dimensions, the community needs, the needs for other disciplines to get involved. Whereas when you're in your training as a doctor, you only see the patient and yourself at times. And so this helped me to understand the population linkages that I wouldn't have otherwise appreciated.
It's really important that you work in teams. Travel with engineers, travel with pharmacy students, because you're going to see a problem and everybody has a different sort of solution to the problem based on their skill set that they're bringing into it.
You work with not only with people from a lot of different cultures, different languages, but people from different disciplines. So it makes, it made so much sense to me then, but I do remember thinking, wow, this is really surprising that we're all going to sit in a class together and we're all going to get credit. And it seemed kind of radical.
The Global Health Program expanded to also include border health in the areas of northern Mexico, only 70 miles from Tucson, Arizona.
We didn't invent border health, but it's totally logical that border health and global health are integrally related because they're of a piece, they're a continuum. So we send people on global health experiences 62 miles south of here in Nogales, Sonora, and we send them 8,000 miles away in Nepal. And they are interesting contrasts, but there is a continuity there that makes it intellectually, culturally, politically, and frankly, morally appropriate, because that's who we are.
This is like an hour south, but it's such a resource-poor area. Nogales, Arizona has 45,000 people, and Nogales, Sonora has 450,000 people. There's no utilities to reach those numbers, so there's water and sanitation issues and nutrition issues and chronic disease, as well as violence and work and occupational injuries.
Dr. Burris Duncan, a specialist in pediatrics, saw an opportunity to reach outside the classroom and into the lives of our Mexican neighbors with disabilities.
Yeah, it was back in 2008. I was told the first thing you need to do is to organize and implement a border program, border conference on disabilities. And so I told them, I said, I'm tired of conferences. I go to a lot of them and I go for 2 or 3 days and I come back home and nothing's happened. Nothing changes. And I don't want to really get involved with that. But if you'll let me do something that will leave something behind after the conference is over, then I'll be more than happy to help with this.
The Arizona-Sonora Border Project came out of the Global Health Program in 2008. Arsobo designs and builds all-terrain wheelchairs, prosthetic limbs, and solar-powered hearing aids, asking the people of Sonora, Mexico, to pay what they can afford. The equipment is built by people with disabilities for people with disabilities. Without Arsobo, these life-improving mobility devices would not exist.
This binational aspect of this program has been a key to the success. I've worked in several binational programs, and this is the first time that I see an equal effort on both sides of the border. It's usually the U.S. coming into Mexico and helping, bringing relief to some of the problems that we have in Mexico. But this time it's really a true binational effort.
If you start from the ground floor and then get your partners involved with it, then it becomes theirs. And I can tell you, as I talk to people who are involved with these 3 different projects, everybody thinks it's their program. It's not my program, it's not Tracy's or anybody else, or Kiko's program, it's their program. And that's what's going to make it sustainable.
Well, we've learned from decades now of global health experience that the power is really in partnerships. None of us can do it all. Partnerships have to be founded on the basis of mutual trust and confidence and relationships in one another.
You don't parachute into countries and assume you know everything and you can make everything better.
You could be the best surgeon, the best clinician, the best whatever in the world, But you have to join something when you go to an overseas setting and be sensitive to the local vision. Your role is really to help your colleagues fulfill their vision.
We all have very idealistic ideas about global health. We're going to go out there, do big things, change the people there. And these people have gone and realized that that's not true. Global health is actually very challenging. You go to a place, you're trying to change a culture that has been there for years, hundreds of years. Trying to change the idea about health, trying to change the idea about how to take care of themselves. It's not easy to do, and there are a lot of failures. And they bring that up. They tell you that sometimes we fail, but that one success makes all the difference.
I think in the academic world, you can get very isolated in your clinic or in your office or in your research and stuff. And you kind of go home with blinders on. And you can't function that way because there's things beyond those blinders. And you have to throw them away and kind of take the broad view of stuff and see what's going on. And that's what this has allowed me to do, to throw away those academic blinders and really see what's out here in this world, because it's beautiful. I mean, if you get all these people who are involved with this, all these partners and stuff who are doing stuff, and they're doing it out of their goodness of their heart.
Many of the 668 alumni of the Global Health Program continue to work in underserved areas. The legacy of this 30-year program can be found everywhere from Sierra Leone to Papua New Guinea to Mexico.
If it wasn't valued by people like myself, it wouldn't have survived 30 years. So I think that's a real credit to Dr. Pust and his team, who have kept this going for so long, and the other faculty. It shows the interest and motivation that there is in global health.
For me, the biggest driver is the fact that it doesn't take much to make a difference with global health at all, actually. It just takes a really good heart and hard work.
In global health, you're kind of always challenged to push the limits of your comfort zone. Even though it's challenging, and a lot of people get really frustrated by the challenges that come up, just the simple things that seem to take forever, or things that you can't do that you're used to being able to do, the triumphs that you overcome when you figure out how to fix a challenge just kind of like keeps you coming back and like thirsty for this idea that if I think a little bit more out of the box, I might be able to overcome whatever is in front of me.
I think for me, it's just the idea that I can do so much with so little with global health and impact so many lives. You just have to show someone that you care. And with a few and targeted clinical skills, you can really make a difference.
The other thing which is becoming increasingly important as the world globalizes is the concept of stewardship. So we have resources. Everybody has resources. It's not that we're resource rich and they're resource poor. We just have different resources. And yeah, frankly, they do have fewer material resources, in many cases, fewer educational resources. But whatever we've been given, whatever luck we've had, not only should we be grateful for them, but they're not infinite. We borrowed the world from our children. We did not get it from our parents.
One of the biggest challenges is support and funding for travel. And I think they're really trying to help us out, but there's so much they can do. So I would definitely push for any support that we can get for this program. It's a great program. It has a huge, big future. It has the power to change so many lives through the few people that they train here. So I think it's a good investment, and I just push for everyone to support it.
And we're really, the way that our program is structured is really making sure that we attract students who have a genuine interest in what it is that they're doing in global health. We're creating students who actually want to make change and are passionate about making change. And though there might not be, the whole class or 100 of us, it's almost better that way because we're surrounded by people at the end of the day that want to engage in conversation and about making change. And I think that that's really powerful.
You could summarize gratitude by thanks. I think you could summarize stewardship by take care. So I guess my bottom line, and we try to say this at the end of any encounter with our students or with our counterparts, is thanks and take care.